Yeah, short. Good morning. So our topic is on measles, which unfortunately has become topical. And I've brought Justin Frederick here with me to provide you with a public health angle on it as well, because I thought that would be really much more interesting. So neither of us have anything to disclose relevant to this particular talk. These are the objectives that I wrote for our session: to recognize signs and symptoms concerning for measles. I'm going to show you a lot of pictures of measles. To initiate appropriate testing and management for potentially infected and exposed people. And then we will describe the role of public health in managing these outbreaks. So my section is sort of on, what do I know? What is there to know? A little bit of flight of ideas, unfortunately, but with the misery topic, misery loves company. And perhaps you'll see where that's going. So the title of a pretty miserable disease. So this is Sean O'Leary. He is a pediatric infectious disease professor at Children's Colorado, and he represents us with the AAP for vaccine introductions and does a lot of work with that. And he was quoted in the New York Times, and I know it's kind of exciting that, I'm in the New York Times, and that was the sum total of the quote from him in this article, is that it's a pretty miserable disease. He was quoted in a couple other articles, but that was the full quote. And I just thought it spoke pretty well to what measles is like. Jessica Taldy, also at Children's Colorado, had performed a survey looking partly at what do people know about measles who are out in practice, trying to get a baseline for where people's knowledges are. And I'm using this a little bit as a framework to help you get to score well on her test, so to speak. And if you look, the black is correct, gray is incorrect, and then the lightest color is I don't even know. So you can see that there is a range of questions on which people did well and didn't do well, with infection prevention issues being right here at the bottom. So I thought I would cover some of that as well. She also asked, and this is probably a lot for the Zoom audience, a survey of practicing pediatricians. Does your practice have a plan, or does your institution have a plan, and how's it going with that plan for potential measles exposures? So I want you to think for a second, do I know anything about what our plan is? So looking at different settings, HMO, hospital or clinic or private practice, you can see some people are like, yes, we have a plan, we use it all the time. Another chunk of people were like, yeah, we have a plan, but we only use it when we feel like there's a threat and we need to use it. And some are like, no, we don't have a plan, or I don't know what it is. So when I was first, in peds and such, what did I know about measles? I knew it was first disease, right? I mean, we only really talk about fifth disease, but measles used to be a big deal, so it was the first disease with a rash. It had 3 C's and kind of a K, and this is like the stuff you're supposed to know. And then there's this other C that it's super contagious, so maybe 4.5 C's if you count a K as kind of a C. And then there's pneumonia, and there's SSPE, and then these children I consider the celebrities of measles, because I feel like I have seen these children's pictures so many times that if you see those pictures, the answer is measles. So I want you to see other children who have measles, because I feel like this is all that we have in our heads because they're free and available, and so people use them all the time. So incubation period. So here's our little child. They've inhaled some virus, and now they've gotten infected with measles. But there is this long incubation period, and that's going to be important for trying to figure out who they were exposed to, who they got it from, and also who they've exposed and who might have gotten it. So 8 to 12 days. The range is usually within 7 to 18 days. And then they start to this period of communicability where they start to be infectious to other people. So long incubation period, and then a pretty good chunk of time where they're infectious. You notice that they haven't had any symptoms yet, but there's this little zone of a couple days where they could be infectious but they don't have symptoms yet, so they're not isolating or doing anything like that. Okay, so once it comes in, it's a respiratory virus. It gets into the respiratory system, but it uses ways like Nectin-4 and SLAM. It uses different cellular receptors, and it gets through the tissues, and it goes everywhere in the body, and so you start to see manifestations of that. And so the onset of prodromal symptoms starts with fever. These fevers can be progressive. They can be very high fevers, 103, 104. So it's a very prominent fever, and they have it through this whole period. And then the big three, right? Cough, coryza, and conjunctivitis. If someone says the word coryza to me, I also think measles, because that's the only time we call runny nose coryza, near as I can tell. But the conjunctivitis, it's not like adenovirus purulent kind of stuff. It's described as watery, and all the pictures I have, the children, it looks very red in the eyes, but watery discharge. So I tried to get a picture of this child with minimal rash, but like really with that conjunctivitis. But non-specific, right? Lots of kids have runny noses and watery eyes and a fever. It's not very specific, unfortunately. Koplik spots are, they're an enanthem, so they are a change on the mucous membranes, and we'll show you some pictures of those, but those only exist for a day or two, but if you're watching for them, you can find them. They're usually here inside the buccal mucosa. They're like grain of rice described, or bluish, whitish, and you'll see some other pictures of those later, but they can also be on the palate, but they're most often across from the molars there inside the cheek. And then, just so you know, when we're counting, the day the rash starts is where we count day 0, and we count forward and backwards from that point. The rash, I am showing you a forehead on purpose because this is a rash that is cephalocaudal. So it starts at the top and works its way down. And later when it fades, also fades in that direction. So it starts around the hairline, typically kind of behind the ears. So you can see on this child, it kind of comes down and around. So it's like someone dumped rash on them and it's falling downhill. Okay. And then this slightly weird schematic, but if you kind of look at one side and then look at the other side, it gives you an idea. Not only is it spreading down, but it's becoming more dense. It can become confluent. You see a lot of rash throughout the body, and so it gives you an idea what the spread looks like as this rash is progressing. And here's some more rash, right? And so you can see it can be a little bit denser here on the buttocks, but it comes down, and it's maculopapular. It is, you know, morbilliform rash means measles-like, right? So it's a morbilliform rash. It's generally not pruritic, but it can have a little bit of pustular stuff. It is not vesicular. If you see vesicles, you should be thinking, oh, maybe this is chickenpox, maybe this is an enterovirus, something else. Okay. And then here's some more children, and just showing you that it can be a little harder to see. It can look a little bit raised on some darker skin tones. It can have sort of a different appearance. So diagnostic testing, if you think someone has it and you're going to test them, we send a couple things. If you send an IgG, you are not looking for this infection. So if you look up here at the top, I very badly tried to draw over it because I could not find a simple enough diagram to show what I wanted, sorry. But the big red bar is where the rash is, and the little yellow bars at the top is where you can find virus. So if you're looking to isolate virus by PCR, by your viral culture, that's the phase where you're going to find it. But if you look at the antibodies, they come up later from the onset of the rash. So when you're looking at a kid who just broke out in a rash and they're in your office and you're going to test them, if you get an IgG and it's positive, that's a sign that they were already immune, probably vaccinated effectively, and you may or may not get a positive IgM at that point in time because it's coming up, right? So you could compare later. You could check, convalescent serology and see that it's gone up fourfold a couple weeks later. And then you can do an NP swab, and we can do a PCR on that, or you can collect urine. So this just says the same thing and shows you another child, that you're looking for evidence of immunity to say, was I already protected? And then you're looking for evidence of infection by looking for the virus. These are children. I also wanted to show you, these children are actually from this year. Some of the ones that have been newly posted at the Public Health Image Library, because their rashes are less dramatic than the ones that people usually show you. So I wanted you to see that there is a range on these rashes. They don't all look super intense and like, yeah, that's measles from across the room. So some of these children, it's much more subtle. And then, of course, you know, when you're looking at a kid with rashes, you're going to be thinking about other diseases. You're going to be thinking, is it parvo? In the little kids, could it be like an HHV6? Could it be an enterovirus? And then I've added to, this is a CDC slide, I've added, you know, Kawasaki and MISC when it existed. It's kind of gone now. But, right, those are other things with high fever and conjunctivitis and rash, and that could be on that differential that you're going to be thinking about it. So I've told you, okay, here are these common symptoms. You have fever, cough, runny nose, rash. Okay, lots of things do that, right? The most common complications are otitis media, about 7% of the time. Diarrhea, actually diarrhea can be before the rash. So that's a sign that it has to do with involvement of the gut mucosa already before the rash breaks out. So an enanthem type picture where the Koplik spots and the diarrhea, the gut involvement comes ahead of the skin findings with the rash. But so what, right? Like, that's not a big deal. There are lots of illnesses that have this kind of description. So why do we make a big deal about it? Well, because it's a big deal. So, and I want to be clear, this is U.S. data that is recent, okay? This is not 60 years ago in a lower middle income country, right? This is recent data of the children who get it. 1 in 5 get hospitalized. Now, some of that's just for observation, but 1 to 4 to 1 in 5 children get hospitalized for a complication of measles, because particularly the youngest children. 1 out of 1,000 people will develop encephalitis. And if you think about something that can infect everybody, that is a large number, right? People are like, oh, that's 1%. That's a huge number, okay? 1 in 1,000, that is a very large number of children to have brain involvement. And 1 to 3 out of 1,000 people will die. So it's a big deal, right? I mean, I tried to do some quick math, try to figure out how many children there were. You can probably fill in these numbers later, but if you thought 1 in 1,000 children died, that's huge, right? So who's the highest risk? Unvaccinated. Unvaccinated, not immune, right? Because it's not circulating here, so either you got a vaccine and you're immune or you're not immune, pretty much. Incompletely vaccinated, and then people with known exposure to measles or recent travel to areas. So it's really, really, really good vaccine, but nothing's perfect, right? So it's really good. Highest risk, infants and children aged less than 5, and then those over 20. So kind of your low risk is kind of your school-age children. I don't know if that's left over from those being people who had been exposed already or not, so I don't know. But when you look at complications, the complications are definitely worse in the younger children, and probably in some older pregnant women we were talking about earlier in the room. It can lead to prematurity. It can be very hard on the pregnant woman. Pregnant women in general are bad at viruses. Babies are bad at viruses. And then people with compromised immune systems. Complications can involve everything. It can involve all, and so when we talk about complications of otitis being the most common and then pneumonia being very common, it can also cause croup. It can also cause different types of neurologic involvement. GI involvement, we've talked about some eye. It can lead to direct eye infection and keratitis that can lead to vision problems. There's also vision and hearing problems from encephalitis and brain involvement, but also at the level of the eye itself. So you can see, and then, you know, just floating over here, death. There are many, many complications because the virus spreads throughout the body and goes to many, many tissues. Measles pneumonia is, and about, 1 in 20 children, it's the most common cause of death for children from measles. It can be caused by measles alone, or you can have a secondary infection. And then the secondary infections are kind of what you would think. So for the most part, strep pneumo, Staph aureus, H flu. Those are the most common secondary bacterial components of pneumonia. And on the chest x-rays, the chest x-ray itself is not always as involved as the patient is sick on these. They have a component of viral pneumonitis too. But you can see also dense infiltration. Now, this is a case of a patient who is immunocompromised. This is an ALL patient, and this is their postmortem biopsy. This dense-looking tissue is actually lung. So lung should have a lot more air and a lot less cells than that. Interstitial mononuclear cell infiltration, multinucleated giant cells, so you can get these sort of bizarre cell fusions that happen, causing this specific type of pneumonia in the hyaline membranes. CNS involvement, there's actually different phases. So like I always thought about SSPE, which is late, but there's different phases of brain involvement. So here, again, that tall bar is the rash. You can get ADEM. It's been called different things in measles, but you can have acute encephalitis, but you can have ADEM, which is, sort of autoimmune and immunologic involvement of the brain without virus specifically being there in immunocompetent people. And that is a very acute phase, peaking kind of in that second week of infection. When you get to the third week of infection, you can see something in immunocompromised patients, this MIBE or measles inclusion body encephalitis, sort of like in the lungs. You can see these, there is virus present, and you get these bizarre cells, and that usually starts somewhere in the 3 to 5 week from initial infection timing, but can be out by a few months and is very devastating. And then SSPE is this late onset problem from, it's basically persistent infection, and you do find evidence that the virus has been in the brain, and it's slowly progressive and demyelinating. And so 3, 4, 6, 8 years after their measles infection, they'll start having personality changes and behavioral changes, and it won't be entirely clear what's up. And then they have progressive decline in motor function. The myoclonus is very typical for this, and they can have specific EEG changes that happen, and then it moves to extrapyramidal symptoms, posturing, spasticity, and they can move basically to a vegetative state. So bad. 95% of it's fatal. The 5% that aren't fatal, some of them do actually recover, which is interesting. But the average lifespan after initial presentation is under 4 years and can be very short, or it can be years. And it's mostly supportive care because we don't have anything that cures this, right? The way to not have this is to not get measles. This California study, Jim Cherry and his group in LA looked at all the cases reported in California from 88 to 91, and they recalculated the incidence of SSPE, and it turns out it was way more common than we knew. So if you got measles and you were under age 5, you had a 1 in 1367 chance of getting SSPE. And if you were less than 12 months when you got it, you had a 1 in 609 chance of getting it. And if you told me I could get a lottery ticket that would win 1 out of 609 tickets, I would absolutely take that lottery ticket. So you do not want to win this prize, right? You do not want a child under 12 months or even under 5 getting measles because the risk is too high for something that we can't treat. And when we go to do diagnosis, we find antibody in the CSF, right? So that's locally produced antibody, and that's how we find it, to confirm it. But if that's not bad enough, but wait, I can give you more. You also get immune suppression from measles. Now, we talk about immune suppression, with lots of infections, but measles might be worse. So there's a drop in your lymphocyte count, pretty common with a lot of viral infections, I'll give you that. But your diversity of antibodies are impacted, and there's some data that all-cause mortality is worse after measles, or all-cause mortality is improved by a measles vaccination program. And this is Michael Mina's paper, which really launched a lot of this, looking also, you know, in England, Wales, United States, Denmark, and they saw this association. And I'm going to show you the most interesting, to me, figure from this paper, which is this. So if you start over here on the right, that big chunk of red are antigen-specific memory B cells. So those are your cells that know you saw something, you know you were vaccinated to pneumococcus, they know that you had a cold once, right? Those are the cells that say, oh yeah, I know, I got it. I know how to make those antibodies. Now look at that huge drop when you get measles. So those cells are gone. So you're not just like not having a great time and not having good lymphocytes response. You've lost a lot of your memory cells that were making antibodies for you. So you kind of have to rebuild your immunity, right, over time to other things. So you lose diversity in your own antibody response. So it puts you at risk for other things, right? So I always felt bad, like if measles was the vaccine you didn't want. It's like, well, if you get measles, besides all the bad measles stuff, it also is kind of bad for all the other vaccines you did get. So bad news. Okay. So the disease sounds bad, but, you know, Ebola sounds bad, and we don't worry about that every day, right? Like, so what's the risk? During the pandemic, you may have heard a lot of discussion of R0. R0 is the idea of if I'm infected, how many people do I now hand off to the next wave of infection, right? And so this is, if you're really old like me and you remember a certain shampoo commercial and they told two friends and they told two friends and they told two friends, that's how exponential things go. So this is just for an R0 of 2. You can see that one person on average, so, you know, one person who's infected might stay home and infect nobody, right? Because they don't get out of bed, they live by themselves, nobody gets infected. Someone else, social butterfly, goes out, goes to, you know, and infects 12 people. But on average, 2 people, right? And then you can see that progressively it would spread. So what is it for measles? Well, measles is the one that we always put on the right-hand side of the graph when we're talking about R0 because it's super high. It is always our measure of what's a large R0. It's always over there on the right, or in this case at the top of the graph, to say it's got an R0 that's like 18. And if you think about the asymptomatic period and then that lag in knowing that someone's got infected after they were exposed, right, you can see how that can cause a big problem in a hurry. This is vaccine coverage, the first dose of measles vaccine coverage around the world. But I'm using it because I didn't have a great map of measles around the world, but it gives you an idea that, you know, like most things, medical, things aren't evenly distributed. So some areas are higher risk than others, and some of that has to do with whether we're able to effectively get vaccine to people and get them vaccinated. Okay, so that's an important epi point, which is that we don't have it, to my knowledge, circulating in Douglas County right now, right? But our risk would be people who travel. I also really like on this graphic the CDC made that the nose of that plane seems to be right over Omaha, right? So it's us, right? So somebody can go travel, boom, they land here, right? We could have it. So what's that mean if you're in clinic? Well, so let me tell you a story about Michigan. There was a patient who was a 7-month-old adoptee, came in and developed rash and measles, which wasn't originally recognized as measles, around about 16 days after arriving. So it was first seen in the office on November 14th, was there for about half an hour, said, oh, you have a rash and bilateral otitis, right? You know, maybe you have some virus, whatever. No cough at that time. They came back 2 days later and they were coughing, 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 and held by their mom and really feeling miserable and dehydrated, and they were there. And turned out to be measles, and a bunch of people got measles. So what happened really? So of the children who got measles, that dark bar is the child who had measles originally, who came into the office and the times they were there. The other children, one of them overlapped a little bit time in the office. The other ones were there well after that child had left. No interaction with that child, right? Nothing face-to-face. And here's a map of the office. Child number 1 came in, was in the waiting room, went over to exam room 2, was there for a while, and left. Patient 2, who overlapped a little bit, but not face-to-face in the waiting room, went way over here to exam room 4. They got sick. these other children who came later, when the child wasn't there, one of them went to the same exam room, but some of them went to other exam rooms, and they all got infected. Okay? So then they looked at all the children who had come in on that day and the other day that the child had been there, and they looked and they said, who got infected? Well, you got infected if you were young and not immune, right? And so that was really important. But you got infected up to an hour and a half being there after that other child had left. So if that doesn't make you nervous about your practice, you're talking to me. So prevention. I mean, in theory, we could try and like not have planes and keep people out, but that doesn't really work, right? Like that's not going to happen, and somebody's going to arrive with it, and that's going to be. So shots, right? Vaccine works great. Very pro-vaccine. It works great, and now we give 2 doses, right? And then the other way to prevent it is that if you have someone with it, maybe get them to stay home, maybe put up ways to keep them from breathing and sharing air with other people. That was the way to do it. So here's vaccine. Instead of the usual graph where, you know, you see the cases and it plunges, I thought this was kind of a fun, different graph. It shows you by state what it looked like before the vaccine was introduced and then after the vaccine was introduced. So if you like to look at Nebraska, I tried to underline where Nebraska is because all 50 states are on there. They've only labeled some of them for reference. So I think I've picked Nebraska, but you can see that even in Nebraska, the vaccine being introduced led to a drop in the cases that we had, okay? And then their recommendations, the Red Book, new edition, just out this month, just got it. And it's now online, and you can get to it through EPIC, has recommendations for who to immunize and how to immunize them. So you can look there, and there's all sorts of great information there. The CDC also has created a toolkit that you can use, you know, an idea to get through all these different ways to think through. If you're dealing with an outbreak, you might want to flag everybody's chart that's not immune, right? So you know when they walk in the door whether they're immune or not, right? That can be very helpful. The AAP and Project Frontline made this nice handout. It's a one-pager. I turned out to have downloaded a version, and it appears when I looked at it last night online that they've slightly modified it, so my format's a little different than the one that's up there now. But same idea. You might want to have a pre-visit triage, and then even decide if they need to come into your facility, right? Like maybe they don't need to come into your office. Or if they do, can you get them right into a room with the appropriate safeguards in place, right? But maybe they don't need to come see you, right? That's the best way to keep it out. And then they have additional information about infection prevention precautions that you need anyone who's going into care for them to wear an N95 and have proof that you have immunity. So an N95 is not sufficient in and of itself. You should also have evidence that you're immune before you go in that room because it's super contagious. Normal cleaning works for the most part, but if you're not in an air room, you're not in an airborne competent room, you need to shut that door. You need to leave it empty for at least 2 hours before you put anyone else in there. But if based on that study I just showed you of those kids, that may not be enough because a lot of times there's air mixing between your rooms in the ceiling overhead and like door opening and such. So the air mixes and gets around. So again, trying to keep them not in your office is great. Masking the patient and the family because they may or may not be symptomatic yet. So you want to mask everybody. Post-exposure prophylaxis. So we have post-exposure prophylaxis. We can do it with vaccine. We can do it with immunoglobulin, either given IM or IV. The important thing about that is timing. So you have to find those people. You have to find them right away. And so the health department will be your best friend. EPIC, people who are smart and can figure out who was there that day are your friends. You want to find people as soon as possible because if they need some sort of prophylaxis, you have to find them soon because it's a very small window. Contact tracing. Okay, and then the Red Book also has great tables on who to give what, basically, you know, who's competent to get vaccine and can get vaccine, and who it's safer for them to give them immunoglobulin. Like if they're under 6 months old, right, you're going to give them immunoglobulin like that. And then also pregnancy. One of the reasons that we don't give the vaccine in pregnancy is also the rubella part of the vaccine. So we would give immunoglobulin and not vaccine in that situation. Now the good part, I'm going to hand it off to Justin. Ed. How do I find his? Aaron will bring those. Okay. I'm going to stop touching things.
Well, good morning. Excuse me. Good morning, everybody. While they pull up my slides, again, my name's Justin Frederick. I'm the Deputy Health Director with Douglas County Health Department, and I just wanted to thank you for having me here today. I am going to focus more on the public health response to a measles outbreak that occurred in 2010 and talk a lot about how intense resource-wise it is, both for public health but also for our healthcare facilities and community.
Let's give this a try. Okay, there you go.
So I'm going to start with, this is a new reality to a really old problem, and many of you might know Roald Dahl, who is a famous British writer. He wrote Willy Wonka and the Chocolate Factory, but he actually had a daughter, his eldest daughter, who died from measles, and as Dr. Sato said, 1 to 3 per 1,000 cases will result in death. He was actually a really big advocate for vaccine. And as we all know, measles was eliminated from the United States in 2000 and from the continental, from North America in 2001, 2002. And here we are with this big resurgence. So this is a graph, or an epi curve, if you will, starting in January of 2023 through current date. Last year, we had about 52 or just over 50 cases. In the first 5 months of 2024, we're already at 132 cases. A lot of those occurred in Illinois, which I'll show you here in a minute. So we're definitely trending in the wrong direction. But here's the U.S. Measles cases in 2024. Again, you can see Illinois in that dark blue. They actually had a single case in a 1-year-old in an immigrant housing facility. And that one case resulted in more than 50 cases and 800 people needing to be vaccinated. So not only was this a big strain on, again, public health to vaccinate all of those folks and do all the contact tracing and identify potential cases and community exposures, but most of the cases this year, over half of them have been hospitalized. I know that Dr. Sato talked about that, and we're actually seeing a bigger percent of pediatric cases needing hospitalization right now. So with measles, we need to maintain a 95% herd immunity, right? So 95% of our population needs to be vaccinated, and unfortunately, since COVID-19, we've seen a large decrease in vaccination rates among kids. And so this is all 50 states, and you see the majority of them are actually less than 95%. Some of these cases are actually quite surprising to me. And I was just told today that Nebraska has now fallen to about 93 to 94%. So we're actually below that 95% herd immunity as well. So I'm going to talk about, excuse me, I'm going to talk about an outbreak that occurred in 2010. And keep in mind, the entire premise of public health is to break that chain of transmission in our community and prevent cases. So we rely on our healthcare friends, all of you, to quickly identify cases, notify us so that then we can start that contact tracing, which we're all so familiar with from COVID-19. So I'm going to tell you a little bit of a story here. It all began on Tuesday, May 11th of 2010. I got a phone call in the evening from a neighbor living next to some grandparents who had grandchildren visiting from Hawaii. One of the children had this rash fever illness, so Grandma called the neighbor and said, "Can you come over and check out my grandson?" Neighbor comes over and says, "I think this is measles," picks the phone up and calls the health department. And I answer the phone. I had been a public health practitioner for 10 years, never seen measles. I really didn't know a lot about it because I didn't think I'd ever seen measles. And I thought, okay, well, does this guy really know what he's talking about? And then he proceeded to tell me that he was the index case to a large outbreak of measles on the Creighton campus in 1990 when they only required 1 dose of MMR. So then I thought, well, maybe, right? So then on Wednesday, May 12th, I went to the office, read everything I could on measles, and I picked the phone up to do an interview. And I quickly realized that this is quite extensive, from travel history from Hawaii to California, where they had been vacationing and attended multiple amusement parks, and then all of the community exposures that had occurred here in Omaha since the index case had onset of illness. So I was preparing to head out to the home and do an interview. I was taking a nurse with me. I was hoping to collect some blood so that we could do an IgM antibody. And out the door we go. And as I'm running out the door, I was telling Dr. Simonson this earlier, I was calling my mother to make sure that I, in fact, had 2 MMRs before I went into this house. So while we were there, we attempted to collect some blood on the patient, but the patient was very dehydrated, and my nurse wasn't used to drawing on pediatric cases, so we were unable to do that. And at the time, we requested a voluntary quarantine. And there was a lesson learned there, and I'll tell you about that here in a little bit. About the case, though, it was an 8-year-old male who was unvaccinated for measles, mumps, and rubella, a non-resident of Nebraska, which complicated things even more. They didn't have a medical home here. They didn't have a pediatrician. And they were vacationing in California prior to their arrival here in Omaha. If you see at the top, I have a nice timeline that you can track with me as Dr. Sato described the illness. We start with our onset of prodrome, which happened on Friday, May 7th, and the index case had onset of fever. And that day they attended Mass, they stopped at Hy-Vee for some donuts, and then they went to a garage sale and they went to the Omaha Zoo. So the Omaha Zoo was a huge community exposure. We had 10,000 people at the zoo that day. We had 68 schools there from 5 different states and over 3,000 students. And then on Saturday, May 8th of 2010, he developed fever of 102, cough, and conjunctivitis, and they went to Target. On Sunday, there was no change of symptoms, but they attended Mass, which was Mother's Day Mass. We all know that's usually a full house, so lots of community exposures there. And then on Monday, May 10th, the patient developed diarrhea, vomiting, coryza, and on Tuesday developed rash. This is actually the 8-year-old index patient, and you can see the rash on the face. As was described earlier, rash always starts on the face, works its way down kind of the trunk of the body. I had never seen a rash like this, so I was pretty certain that we were dealing with measles. Subsequently, this is one of the siblings. There were actually 4 kids total that were all unvaccinated and visiting. This is sister who developed measles a bit later, and I'll talk about that here in a sec. These are actually those Koplik spots or those pathognomonic lesions in the mouth. As described by Dr. Sato, they kind of look like grains of rice or sand on the mucosa. I've got a couple pictures here to share with you. So I'll continue with the story here. So then on Thursday, May 13th, because we were unable to draw a specimen, we actually arranged for our medical examination by our health department's medical advisor, who was actually Dr. Kari Simonson at the time. And working with her and the amazing infection control team here, we're able to coordinate the use of a negative airflow room down in the emergency department. I was telling a story earlier, and it always makes me laugh. I brought the patient in the back door. We put them in negative airflow. Dr. Simonson shows up and she says to me, you know, kind of tell me what's going on here. And I learned that she wanted the history and kind of physical on the patient. I didn't know that until I went home and watched Grey's Anatomy and was like, ooh, I blew that. So lesson learned. We went ahead and we collected some specimens, and then we worked with the Nebraska Public Health Lab, and we sent those off to the Mayo Clinic because we don't have, because measles was really not much of an issue then, we didn't have the technology to run the IgM antibody test, so we sent that up to Mayo. And in preparation, we started drafting physician advisories and press releases. On Friday, typical public health, we got a very strong positive measles IgM result very late in the day. That physician advisory we sent out through the HAN network, which many of you I hope are familiar with. If you're not, talk to me afterward or please contact me. I will get you connected. We had to contact all the establishments to let them know that they were going to be mentioned in our physician advisory and also in our press releases because, again, my job is to make sure that I'm breaking the chain of transmission. So I need to not only notify the medical community should they have a patient come into their clinic or into the emergency department with a rash, fever, illness, but I need to notify people who may have had a community exposure at the zoo or at church or at the Hy-Vee, right, or Target. We issued press releases, we did lots of media, we did what is called an Epi-X notification where we can notify epidemiologists across the country. Again, measles was very rare back in 2010, so we were kind of doing a call for cases and also to notify them that there had been extensive community exposures in Nebraska. Again, we had 5 states, schools here, or schools from 5 different states, so we contacted all those state epidemiologists to let them know which schools were there so that they could reach out and do some active surveillance. This is the physician advisory that went out, and it really focused on those community exposures and then action steps that physicians and other medical providers could take if they had a patient come into the clinic, again, with rash, fever, illness, or if they had a community exposure and they weren't up to date on their MMR. So then on Sunday, May 16th, this is where we kind of messed up. If you remember, I told you that I had asked the family to voluntarily quarantine, but what we failed to do is actually give them a written voluntary quarantine order that they could hang on their front door on the inside, not notifying the neighbors, but to remind them that they weren't supposed to leave because we had an uncle come to town who took one of the siblings out into the community, and that very day, that sibling developed onset of prodromal symptoms, and they went to 4 places in town, a couple bookstores, and the KFC. Then on Monday the 17th, all 3 siblings had onset of rash, and we brought them back to the hospital for medical examination and some specimen collection to confirm that they did in fact have measles. So confirming the fact that they had measles was really important and their onset date. I spent many days on the front porch with them having popsicles and ice cream cones because I had to document when each of them had onset of rash so that we knew when we could release them from isolation and they could return to Hawaii. They were supposed to return before or while they were infectious, right? So I said to the family, you can't go. Can you work with the airlines to switch your airline tickets to change your itinerary? They called me back and said, the airline said no, and it's going to cost us $10,000, so we're flying out tomorrow. And I said, well, that's not going to work. And so I called the Minneapolis quarantine station, and I put them on the do not fly list. But then I did help them arrange their tickets home free of charge, and so that worked out well. But again, stopping that chain of transmission, we couldn't put them in a public setting like on an airplane in an airport. On Wednesday, we ended up having to send a second physician advisory and HAN because of those additional community exposures. Again, lesson learned as far as the quarantine orders go. So the plot thickens a little bit. If you remember Dr. Sato saying, you know, the job of an epidemiologist is not only to stop the transmission and identify those community exposures, but it's also to try to find out where did this come from. So we knew in California back in April of 2010, they had 9 cases of measles, and 3 of those were actually genotype D9. And that genotype matched our cases here in Nebraska. The genotype D9 was There was a lot of that, if you will, in the Philippines, and we had a foreign exchange student that was one of the cases in California, and then we had 2 additional cases because of exposures to that individual. But we were never able to link our case to those 3 in California. It was kind of funny. Mom sent me a picture of this man standing at Legoland. She said he was coughing and you know, he had this runny nose and things, and she goes, I think this is where my kid got the measles. And I had to remind her that I wasn't the FBI, I was the health department. But again, this was nearly 15 years ago. So I just want to stress the amount of resources it takes for public health. And this doesn't even take into consideration the resources here at the hospital with using the emergency department, using the negative airflow rooms, using the physicians here and infection control. But we had 16 staff that were dedicated to this response and almost 600 person hours. I myself was in constant contact with the family. Again, I was on the front porch outside having popsicles documenting onset of rash and 4 days after so that we could send them home, and coordinating the specimen collection and all of the communication to our local providers and our community. So again, taking into account this was 15 years ago, so either double or quadruple this. The total cost for public health was about $20,000. So today I would say we'd be between $40,000 and $60,000 for one case of measles in our community. Again, completely vaccine preventable, right? So not only all the terrible things that Dr. Sato was talking about regarding the health of the child and the R0 and the number of people that are exposed and how infectious it is, but there's a cost associated to it for all of our communities as well. So in conclusion, and I'll wrap this up and then we can answer some questions, I would say that we need to remain relentless in our efforts to vaccinate our young people. That should be priority number 1. Measles is still occurs in epidemic levels throughout the world, and we saw that some vaccine rates throughout the world. And things really are an airplane or ride away. I think we know that the best in Omaha with some of the resources we have with a biocontainment unit and the national quarantine unit. Anything happening in the world, we're constantly watching because it could literally land in our backyard. Measles is on the rise in the United States again. It's key that we rapidly detect measles cases, so making sure that all of you are aware of case counts and what's occurring. And when you have a patient come into your office who has a rash, fever, illness, we're collecting really good history that will help us determine whether or not this should be on the differential. And it's, again, important public health, healthcare systems are educated, and an outbreak has a significant impact on all of our resources. With that, I just want to say thanks for having me again. It's not very often that public health gets to come out and visit with you all at Grand Rounds, and I think we're happy to answer some questions.
As far as we know, no emergency currently.
No.
Can I flip back to mine real quick? Is that possible? Escape. Can I make this one small? Yeah. Okay. I stuck this in here.
Oh, it's good. I was going to say, too, we had no additional cases of measles in our community. Yay. So, yay.
Good team. I just put in here what happens here, just a little summary that Melissa Schiesler helped me put together. If we have a patient with possible measles, please call infection prevention. And then, review the patient chart, talk with the provider, and then we would end up talking with the health department about this to decide whether they need testing. So we would make sure immediately that they are in the right kind of isolation, they're in the right room. And if not, we have to do a whole workup. So we run a report, we try to figure out when they came in, where they were triaged, which rooms they were in, and then we have to look who was in the waiting room at the same time, right? The index case for up to 2 hours after they came in the door, And then if they're on an inpatient floor, then we do, sort of an inpatient workup. And we have to identify who's been exposed, and so we have to let people know that they were exposed. But also a list of staff who were exposed, right? So vaccination has changed over time, right? So if you were born before 1957, people assume you've had it. The vaccine was introduced in like 63, but there was a bad vaccine that was a killed vaccine that was given for a handful of years that led to atypical measles. So if you're old like me and not younger like Justin, my measles vaccination card just said measles. 1968, like no idea which vaccine it was, what kind it was, I don't know what it was, and then we didn't add the second dose for a long time. So I came across this little bit of nerdism when in the 80s, and I went to the health center and said, give me an MMR, and they're like, okay, weirdo. But it is officially, and you can find it in the Red Book and the CDC now, but there was a vaccine that wasn't great, didn't work very well. So, we have to go through and we figure out now we mostly have titers on staff or know if they were vaccinated because y'all are young and you have good vaccine records. And then a list of patients in the rooms adjacent. So remember, it doesn't have to be the same room. It can be a room nearby and figure out who is exposed. So we had a suspected case recently. There were 3 phone calls between IP and the health department, and then because of geography, we have to figure out which health department sometimes besides ours. Messages, IP talked to the ID doc who was on call. Please do call us. And then talking to the lab, making sure we get the right things. And then we had 7 staff members who did have to report to employee health because of possible exposure. And then 17 charts were reviewed that met the exposure criteria. And then 12 would have needed, but fortunately this child didn't have measles or you would have heard about it. But just to give you an idea what happens if we have a suspected, we have to do this already up front because they might come back positive tomorrow, in which case, we need to know all these things. So, and then also they'd had an outpatient visit earlier that day because people who are sick with these things never go one place, right? I mean, they didn't even go to one bookstore. They went to all 3 bookstores, some of which don't even exist, right? So people never go one place if they have something contagious. That's like a rule. So just for this potential of an exposure, it was at least 2 hours of IP time here. So just to give you a scope, but I just saved that for extra. All right, what questions are there? I can't see. Are there any?
Nothing yet.
Okay.
Some from the audience.
Dr. Sato, you covered this briefly just now, but for those of us who are old enough to have actually had measles and have had home quarantine and house calls from their pediatrician, do we need to get an adult MMR? Is this kind of like the pertussis, grandma gets a Tdap scenario?
So I'm looking at Dr. Neiman, who's our employee health doctor and also a part of our public health system. But a lot of places, so I'm just going to speak generally, require that you get titers done as part of your work profile. She's nodding at me, so I'm doing okay. Rather than relying on that vaccine information, right? So because, it's good, but it's not perfect, or and then there are people who have, acquired or discovered immune system issues, right? So I might have been vaccinated, but now I'm on chemo or something, right? So even though I'm vaccinated, I'm still high risk. So, a lot of places will ask you to get titers done to make sure that you have a good level and then get a dose if you need it.
Thanks.
Yes.
Thank you for the great talk. My question is about management for those who have measles, and you mentioned one of the CNS complications is ADEM. Back in the day when I was a resident, when I had ADEM cases, we used to give immunoglobulins. Is there any data that showed some sort of alleviated complications if you give those immunoglobulins, or you don't? I'm just curious.
I would consult neuro.
Okay.
and ask their opinion.
Yeah.
I'm not sure. I don't do tons of ADA management and never by myself,
Okay.
because I always want their help.
And then,
So I would go with what they tell me is current.
question for Justin, did you follow those cases like years later, and see if they had any complications? No? Just, again, curiosity.
The question was if we followed the cases years later, and the answer is no, because they returned to Hawaii. So we turned them over to their local public health jurisdiction. Yeah.
Justin, can you talk a little bit about voluntary quarantine and what measures the health department, I mean, we encounter this with different, you know, obviously COVID and then MERS before that. When I was in fellowship, there was a non-compliant voluntary quarantine issue. So can you speak to what the health department, what measures you take, I guess, short of a no-fly list?
Yeah, that's one thing we can do, right?
Yeah, that's
so the question was discuss voluntary quarantine and kind of what we would do if we had to enforce it. Is that kind of what you're okay?
And what is it asking? What does the letter say?
Oh, the letter basically. So we when we issue quarantine isolation orders, we always try to be as least restrictive in mandating, right? So, but it would be all the same thing. Stay home. Up to 21 days incubation period. If you don't develop symptoms within that time, then you're good. You're free to go. Things like that, right? So, but anytime that we issue an order like that, the individual's needs, their daily needs, become our kind of problem, right? So we're responsible for assisting them with food and getting medication and doing all those sort of things. So again, we try to be as least restrictive. If we have to do a mandated health order, we can. But COVID really complicated things. Public health has been under attack a little bit regarding some of the authorities that we have to do those things. More so on a community-wide basis, like mask mandates and things. We still have quite a bit of flexibility if we need to do something on an individual basis. Tuberculosis, for example, there's actually written into the state code that we have the authority to do X, Y, and Z, and even go before a judge if we need to. So, yeah.
Got a couple things that have popped in on the chat. One of the neuro colleagues has weighed in and said, first-line therapy for ADEM is corticosteroid, not IVIG, usually 30 milligrams per kilogram per day for 3 to 5 days and some sort of taper. So, to your question there, that's from Dr. Thodeson. And then a question from Dr. Josh Bees. Do you have the data for incidence of encephalitis and death specifically in kids under 12 months? Incidence of encephalitis and death under 12 months.
I don't know off the top of my head, sorry. But everything's worse when you're younger. Right, the number that I know best is the SSPE because I had changed, but encephalitis is still higher risk when you're younger.
Sure.
Question for Dr. Sato. For us, the trainees, because we do share a lot of time in continuity clinics with general pediatricians, and vaccination is such like an important part of that clinic. And we, as trainees, understand that vaccination does prevent this kind of disease. We still face a small percentage, thank God, of families that are hesitant to giving vaccinations to their child. Most recently, I came to like a second scenario where a child has received the first dose of the MMR vaccine, but then as we get onto that kindergarten appointment and we're supposed to get that second dose, parent questions, oh, does he really need the second dose? School seems to be a little bit flexible, so obviously that also like makes the parent second guess if I should get it. From your perspective and your specialty point of view, what is sort of like your one-on-one spiel briefly for us trainees to like kind of aboard or like embrace that conversation with these families?
So you certainly could take the route of sticking that child and running titers for the viruses to see, what the titers are, but it's always better to have that second dose in terms of effectiveness. The other part, so this is just a little nerd point about IVIG. So MMR is live, right? Those are live viral vaccines. And so if you have lots of antibody around that bind, they think it's probably more B-cell receptor cross-linking that is interfered with by having high levels of antibodies, not necessarily neutralizing antibodies to the viruses. But regardless, it can interfere with the ability of the vaccine to work as a vaccine because you already have antibodies that are in the way interfering. Right. So when you give varying doses of IVIG, you have to wait. And it's the same as babies, right? Babies get some amount of measles antibodies from their moms transplacentally, and so they have antibodies. So it's safe to give the vaccine down to 6 months of age. And we do that if someone's traveling, someone's going to be, or in an exposure situation, we give it down to 6 months of age, but it doesn't count towards their vaccine status because we're not sure if they had enough antibodies around, whether that worked as a vaccine, right? And that's why there's a table, just go look it up based on the dose of IVIG in the Red Book. You just know that there's a table there and you go look it up. But if you got treated for Kawasaki, right, it's 11 months that before you give MMR or varicella again, because that amount of antibody is going to interfere. With the issue is when you give it at 12 to 15 months, if mom had super high titers, it's possible it didn't work very well. It's unlikely to be a cold chain issue, that the vaccine wasn't any good and it didn't work because of the cold chain being interrupted. If you're getting vaccinated here, right? Because we have good cold chain for our vaccines. But it's a second dose to catch people that it didn't work the first time. And is that it's always better to get a second dose. But, if they're really against it, one approach could be, you get the titers, and then if the titers aren't great, then you give it. But the measles part of the vaccine kind of has a longer hang time than the rubella part of the vaccine. So, and it's covering more than one thing. So I just, recommend, and they're more protected because their immune system's already educated a bit about how to respond to these viruses. So it's just, giving additional education to their immune system and helping them be ready in case something comes along.
The CHOP Vaccine Education Center has some really good bullet points for pediatricians.
Yes, Dr. Greenhines is pointing out that CHOP has an excellent vaccine education center with all sorts of resources. It goes over all sorts of things. It tells you about aluminum. Yeah. It tells you about formaldehyde. It goes through all those things, and it's really good to just kind of wander around in there and look at stuff.
The AAP also has a resource for that. So if you haven't already as a resident, it would be really good, especially if you're thinking of going into primary care, to use those resources and become familiar with them.
Although I argue that everybody should be promoting vaccines.
Yes.
Right? I mean, it's important for neonatologists to push some, and oncologists, and neurologists.
There's an app for that, the CHOP Vaccine Center, so handheld.
Yes, and the Pediatric Infectious Disease Society has a bunch of vaccine resources also freely available on their website, pids.org.
They're just good to get, instead of, getting to the nitty-gritty kind of thing, just kind of how to approach parents who are hesitant about vaccines.
Yes.
Public health question.
Ooh.
Aside from a no-fly list, it would seem poor behavior for an airline to charge $10,000 to change flights in this situation. Is it possible for a public health department to step in and force the airline to be cooperative?
Yeah, and that's what we did, but they were scheduled to leave the next day, and I didn't want to run the risk of them getting on an airplane and exposing hundreds of people on a flight. If we would have had more time, I would have tried to work with the airlines. I'm really wondering who picked the phone up on the other end and didn't think I need to get a manager to see if I need to switch these tickets. But yes, we try to be as least restrictive, as least invasive in people's lives as we can be. So we would maybe tried a different route. Yeah.
And then back to you, Dr. Sato. From your experience, is there still a concern from families that MMR can cause autism? I know there's no scientific evidence behind the study that sparked that concern, but I still hear people, general public, typically older people, that reference it and talk about concerns with vaccines being linked to autism. If you encounter this, how do you address it?
Yeah, so this is rapidly aging me, but I basically started Pediatrics around the same time as the Wakefield paper. So I've had more than a couple decades of dealing with this particular journal article, which is retracted, by the way, and was heavily conflict of interest for him wanting to market his own vaccine pathway that was going to make him money, and like the whole thing was horrific. That said, regardless, people took it in good faith and did all sorts of studies to say, is there a link or not? The answer is no. I mean, like on country levels, people looked at whole population levels. People looked on small levels. There was an autism foundation funded study looking at like siblings that, and whether the vaccinated sibling was more likely than the unvaccinated. There were all sorts of studies done that said, you know what, it doesn't seem related. It's just you happen to get this vaccine around the time most people start to be diagnosed, right? So it's like true and unrelated. That said, can you win every discussion? No. Do people come to see me on purpose because I'm an infectious disease expert and they want my opinion, but not about that? Yes. That happens a lot. And you're like, you know, you drove out of your way and asked to see me for my opinion. I would like to give you my opinion. So it's hard, right? And sometimes it's just people need reassurance that really it's okay, right? And that the vaccine is a good idea. And people really like their own providers, and they really trust. So what I tend to say is, you know, I've thought about your child, and your child would really benefit from this, because they don't want just like everybody should get it, right? They're like, oh, but we have this and we have this. It's like, I'm specifically thinking about your baby, and I think this is right for your child, right? And then there's some advisement about the language of it. So, you know, if you describe it as a weapon and it doesn't work 100% of the time, then it's a failure, right? People are like that with the COVID vaccine. Well, it doesn't prevent 100% of cases, therefore it's useless. That's not true, right? So things aren't 100%, it's not perfect. And then the idea that if you give the idea that it's a weapon, then it has to still be there for it to work, right? So then people get the idea that it's hanging around and it's there forever, and they're giving their child something that will be there forever, right? Because that's the way it works. That's not how it works, right? If the teacher comes in, it teaches your child how to speak Spanish, they leave, your child still speaks Spanish, right? So there's a lot of language about it. And then just walking with the expectation, like, this is what your child's due for today, and we really think that that's a good plan. And not, well, what do you think? Right? It's that having an attitude that, you know, really, like, also specifically I've thought about your child, but like, this is really the best plan for your child. The same as I would argue that they should get enough sleep at night and, you know, wash their hands, right? Same kind of thing. And you won't always win. I'm sorry.
Dr. Locke points out that Wakefield lost his license, but the last time she checked, he was practicing natural medicine in Texas. In Texas,
yes. That is correct. That is correct. Makes me want to be religious. I think. Yes, ma'am.
Question, Justin. I don't know if you know this, or maybe you know this, Marilyn. With that outbreak, do you know how many kids needed to be rounded up and get post-exposure? Either immunization or IVIG?
Yeah, I don't have that number because the exposures were on such a community-wide basis. Yeah. We didn't have, you know, one specific group that would have had low vaccination rates. And like I said earlier, and Dr. Simonson really wanted me to point out, we didn't have any additional cases related to this cluster or this family of 4. But again, our immunization rates in Nebraska were above that 95%. So today might be a little bit different, right, as our immunization rates continue to come down.
How did that compare to the 2014, 2015, at Disneyland? We had one case, correct? And there was exposures. So that paled in comparison to the 2010.
Yeah.
Yeah.
Yeah, for sure.
Yeah.
Yep. I mean, just at the Omaha Zoo, we had 10,000 people, and then,
Opening of the
yeah.
Madagascar.
Yep.
Right?
Yeah, it was the opening, I didn't say this, it was the opening day of the Madagascar exhibit, so I was a little bit worried because if you've been in that exhibit, the hallways are narrow, the ceilings are low, and it smells like animals. So I don't think there's a lot of air exchange happening there, which could have posed some potential risk, you know, again, up to 2 hours after that individual had gone through that exhibit. Yep.
We are way over. Thank you.
Yeah. Thanks.
Thanks, mysterious Zoom